I am with Synapticure, and joining me here is Oleg, or Dr. Yerstein. He is our wonderful cognitive neurologist here at Synapticure and is excited to give you all a great webinar today. So, a couple housekeeping things just to get through the presentation. If you can put your questions into our chat, we will monitor the chat. So if there's any questions that come up, feel free to add them in. Otherwise, Oleg, feel free to take it away.
Thank you so much, Zach. Today I will tell you a little bit about memory changes, their implications, and what can potentially be done about it, covering a pretty rapid and broad overview of what we do in this field. I will try to make a point to leave time at the end for questions. I do believe we have the full hour to do so. So please, yes, add your questions in the chat, or also you can feel free to ask them at the end of the presentation. Okay. So the first thing that we should start with is, well, let me tell you that I am a dementia specialist. I'm a neurologist who specializes in cognitive and behavioral neurology, specifically memory disorders and other disorders of memory and thinking. And why is this important? Well, this is because memory loss sometimes, or it used to be thought to be just a part of normal aging. And increasingly now we know that some people, when they age, do have memory loss and some do not. And there can be predisposing conditions that can affect the rate of that memory change. And increasingly, we have interventions that can change that trajectory and potentially help slow the progression of memory loss or stop it entirely, depending on the cause. The sooner that an individual is evaluated, the sooner we can figure out exactly what is contributing to their memory loss, and again, hope to change the trajectory of the symptoms that are noted. It is a very exciting time to be in the field of dementia care because just in the last couple of years, we've had new therapies come out that can actually slow some of these disease processes. And that's something that's never before been available in history. But in addition, other than these drugs, there are incredible support services and non-medical strategies that can also be very, very helpful for improving quality of life, which we'll discuss today. And so the first little infographic that I'm presenting here today is from the Alzheimer's Association, and it shows that for an individual at age 45, if they're a woman, they have a 1 in 5 risk of developing Alzheimer's disease in the rest of their lifetime. And for men, it's about 1 in 10. Unfortunately, in part for men, it's 1 in 10 because men are predisposed to multiple other conditions, such as cardiovascular disease, which may affect them before they reach the age to be affected by memory disorders. So let's talk about what is normal and what is not normal memory loss in aging. So it is entirely normal to sometimes forget names of people that you've just met or even people that you've known for quite some time. It's quite normal to forget where you put something or walk into a room and forgot why you walked into it in the first place. It's also entirely normal to struggle with new technology and a new cell phone every couple of years where the buttons are all in a different layout. As long as you can spend time on it and figure out eventually how to use it, even if it's frustrating, that unfortunately is normal. What is a concern is when you notice that yourself or a loved one starts repeating the same questions, sometimes just minutes after you've had that conversation, or that you or someone else will start missing appointments despite having just discussed them the prior day. Increasingly, we notice this difficulty with managing bills, for example, just keeping track of when payments need to be made or making repeat payments, forgetting that they've already been made. A very common concerning sign is when someone gets lost in familiar places, driving to a neighbor or family member's house, or even to the grocery store, which is something they may have been doing for decades. Another concerning warning sign is subtle personality changes. When somebody really is getting consistently more irritable or more agitated than they had in the past without any clear provoking factor. So we should now talk about the term dementia because people hear that a lot, and I'm not sure they always fully understand what it means. So dementia is a very non-specific term. It's what we call an umbrella term. It covers a lot of possible causes. All that the term dementia means is that someone is at cognitive decline that interferes with daily life. So slight forgetfulness that does not Impaired daily functioning is not dementia. At most, if there's some impairment on testing that we may administer, we might call that mild cognitive impairment. But when it really starts to impair independent grocery shopping or driving or managing of finances, for example, because of these cognitive reasons, specifically reasons related to thinking or remembering, that is dementia. Now, Alzheimer's disease is a common term that many have heard, but again, I think often equated with dementia, and they're not the same thing. Alzheimer's is a pathologic disease, and I'll show you more to that shortly, where there are specific accumulation of abnormal proteins in the brain that over time cause dementia. Now, someone now can have Alzheimer's disease because we can even diagnose it before someone has symptoms, but it is not considered dementia until they have that functional impairment. So, if you or someone you know is suffering from mild cognitive impairment or dementia or even significant cognitive concerns and you decide to have an evaluation, let's run through what actually happens during that evaluation. Well, the visit starts with a very detailed medical history, and that is where a neurologist like myself will actually get most of the information that they need. We will go into detail of when did the symptoms start, what are the contributing medical conditions that the individual has, how have these symptoms progressed over time, and have there been any provoking factors or exacerbating factors? After we get a very detailed history, including family history, we perform cognitive testing. Now, sometimes this is done even before the visit, where you're put through various multitude of tests to evaluate different cognitive functions, looking at visuospatial skills, memory skills, attention, and problem solving. Then we perform a neurological examination, checking the motor and sensory functions of an individual and how those might be contributing to overall brain function. And depending on what we find in that evaluation, we will often order additional tests, considering a blood work, brain imaging to see what is happening structurally, and sometimes additional, more involved biomarkers that combine some of these tests. Once we have a detailed picture of both how the individual is presenting and what sorts of, again, pathology or abnormal biomarkers may be accumulating, then we come up with a plan for how to address these changes. So let's talk about a few conditions that may look like dementia in terms of that we think about in terms of neurodegenerative disease, but may potentially even be reversible causes. So depression is a very, very common problem that can cause such global impairment. Severely depressed people can be so non-functional that their cognitive processing even slows down. In fact, some of the tests that we use to look for dementia may even give a false positive because parts of the brain will be functioning less than they're supposed to because depression can be so severe. Now, usually this only happens in individuals who have already had a lifelong history of depression that has continued into older age, but it can sometimes even be sporadic. Medication side effects are a very common cause of confusion and memory impairment. All medications potentially have side effects, and as an individual gets older, their brain becomes less resilient to compensating for these, more vulnerable to being overwhelmed by the medication. This includes very common offenders like opiate medication or benzodiazepine medication, sleeping medications, and even some medications used for allergies, for example, or urinary frequency can also affect memory and thinking. Anytime an older individual is prescribed a new medication, they should review with their doctor whether that medication can affect memory or thinking. Unfortunately, we don't always think about that if we're treating a completely other part of the body. Thyroid disorders are very, very common. The thyroid gland releases these hormones that very much regulate how the whole body is functioning, its whole metabolic rate. And with a deficiency of thyroid hormones, there could be a global slowing of cognitive functioning that individuals may not be aware of unless they've been tested. And likewise, excessive thyroid hormone can cause individuals to be anxious or jittery or unable to focus or concentrate. In general, vitamin deficiencies can also cause confusion and problems with memory loss. Another common offender there is alcohol, where individuals who may drink heavily and not get sufficient nutrition may gradually become depleted in certain vitamins, which can cause severe memory disorders. So it is very important when there is memory loss to get a comprehensive evaluation at the physician, including levels of vitamin levels. And any heavy alcohol use in recent memory should absolutely be reported to your provider. Sleep disorders are another common cause of memory problems. So now we increasingly know that when we sleep, our brain is both consolidating memories and also clearing out toxins. And if sleep is disrupted, such as with a disorder called sleep apnea, where your airway may actually close up during sleep and your brain has to wake you even during deep sleep to remind you to breathe, well, it disrupts all these cycles of memory consolidation and toxin clearance. And an individual who may even sleep 8 or 10 hours may feel exhausted at the end of the night because they didn't get good quality sleep and then still be tired throughout the day and frequently napping. And anyone who's very, very tired can attest to the fact that your memory is just not as good when you're exhausted. But in older individuals, even infections such as urinary tract infections, which could be nonspecific, can cause a global state of inflammation that in somebody whose brain is already vulnerable, may already have some cognitive impairment, may be overwhelmed by this additional inflammation. And it is not uncommon for individuals with potentially mild dementia to look much, much worse when they have an infection, such as a urinary tract infection. So let's talk about Alzheimer's disease. As I've mentioned earlier, this is a specific disorder where these abnormal proteins accumulate in the brain. The first of these is called amyloid, beta amyloid plaque. And as you can see in this picture in the bottom left, these purple kind of lumps here are neurons, are healthy brain cells. But the brain in an individual with Alzheimer's disease creates amyloid, which are these toxic proteins that accumulate outside of cells, and they create these amyloid plaques that affect how the neurons communicate together. Over time, it's not just amyloid, but a second protein called tau starts to accumulate and misfold inside the cells as well. And that creates these neurofibrillary tangles, which are these kind of pinkish reddish lines that you see inside these cells. And again, these further impair the functioning of these neurons to the point where when they accumulate in high enough amounts, these neurons start to die. And when these brain cells die, the brain shrinks as a whole. And what you can see on this MRI image here, we're looking at front to back images of the brain, kind of from the middle of the brain. You can see this is a more or less healthy brain with the neurons themselves are the gray tissue on the outside of the brain, the lining, if you can see it right here. And the white stuff is the wiring, the axons that connect all the brain cells together. As brain cells start to die from Alzheimer's disease, there's simply less tissue around, and you can see that the brain is just smaller and becomes more shriveled up. And these black spaces, which is where the spinal fluid is in the brain, simply take up more space because there is less brain tissue left in the brain. These areas right here in the deep middle of the brain are called the hippocampi, and these are the memory centers in the brain. And what we neurologists look for fairly early in the imaging of those who are developing Alzheimer's disease is that these areas start to shrink even before the rest of the brain does, which is often suggestive of the changes of Alzheimer's disease. As I've mentioned, we're entering a new era of Alzheimer's treatment, however, that in the past we've only been able to focus on treatments, provide medications that help individuals function better but don't change the course of the disease. Well, now we have new therapies that target one of these specific proteins called amyloid. And if we clear it out from the brain early enough, it does slow the progression of Alzheimer's disease. So these are called amyloid targeting therapies, or another term for them is anti-amyloid therapies. And if provided at the right time to an individual who does not have significant risks that would preclude them from starting this treatment, individuals can have a delay in the progression of their disease. Right now, all of these therapies are started as infusions, as you can see here, and they are these proteins that have to be infused into the bloodstream. They travel up to the brain, and there, these little proteins actually bind to that amyloid protein that's floating in that fluid, or that's already formed some of these plaques, and gets your own immune system to see them as something that shouldn't be there and clear it out. And like I said, if this is done early enough in the disease process, it can potentially slow the progression of the disease. Now, for maintenance therapy and potentially in the near future, as an initial therapy, there are injection therapies coming to the market so that even the infusions potentially will not be required in the future. But what can these therapies actually do? So they may slow disease progression for some people, again, if they have only the right pathology, if they're caught at the right stage of the disease, and if they can tolerate these therapies and do not develop side effects. And they work as part of a broader plan of care. They don't work in isolation if there are not otherwise lifestyle interventions. For example, somebody with severe sleep apnea who drinks very heavily, even if they take these therapies, they will still have a progression of their cognitive decline, unfortunately, potentially at even a similar rate. And what these therapies also cannot do is reverse memory loss. So any damage that's done has already been done. We hope with these therapies to slow further damage, but we can't stop Alzheimer's disease. And we still need lifestyle modifications to keep the brain healthy, as the brain doesn't exist in isolation from the rest of the body. So if you are interested potentially in learning more about these new treatments, there are a lot of questions that you should ask. One of which, right, is am I or is my loved one a candidate? And this has to do with the staging the disease accurately, looking at the tests, cognitive tests, and at the functional assessments and the imaging scans and blood tests done to determine risks and benefits of these treatments. Again, the discussions will revolve around what are the potential benefits. On average, these therapies in clinical trials led to about a 30% slowing in disease progression, but it really varied depending on what stage of disease the individual was at when they first enrolled in the trials that showed that these drugs worked. And these drugs potentially have significant risks because these are antibodies that activate your own immune system to clear these proteins out. When your immune system is activated, that can cause inflammation. And inflammation that it goes out of control in the brain can cause swelling or even bleeding, and in very rare cases can even be life-threatening. So there is a lot of monitoring that's required. People have to have 4 to 5 MRIs in the first year of treatment. They have to have regular infusions and frequent follow-ups to make sure that they're tolerating these treatments. And not all treatment is these new therapies. We've had medications now available for over 30 years that help with the symptoms of Alzheimer's disease, medications that can help individuals function better, at least temporarily, although again, these medications do not slow the progression of the disease. And separate from medications for memory or thinking, there are medications for other complications that arise from dementia, for mood symptoms such as anxiety or agitation, for sleep problems, and treatment plans really are individualized. But a lot of the changes that we see from the disease can at least partially be managed with medications and supportive therapies. So if you believe that someone you care about is affected by memory loss or a disorder of thinking, it helps to know how to talk to the individual about these things, right? If you see in the column on the left, if you start telling somebody you're just forgetting everything, or what's wrong with you, or you have a problem, they may disagree because, frankly, if they have memory loss, they may not remember the incident that happened a couple of days ago when they forgot something you thought they should have known. And if you come at them with confrontation, they will be defensive, frankly, and may not want to listen. It helps to really align yourselves as having a mutual interest, and that showing them that you are supportive of them and empower them to seek care that may be helpful for them. So saying things like, I've noticed some changes and I'm concerned, or let's go together and try to figure out what might be going on. Just would you be open to a checkup or doing a screening test for your memory and thinking to see how you're doing? Choose a calm and private moment. This really is personal, and some people can be very self-conscious. I would not talk about it in front of extended family when you're first trying to figure out what's going on. Let the person tell you if they have any concerns. Some people do notice these things early on, and sometimes it is the affected individual who is the first to notice. But I would say just as often, if not more often, it is the spouse or family member that notices these things potentially even years before the affected individual has any idea. So what if they resist help? Don't force it. If you're pushing too hard, they may not trust you. If you schedule an appointment without telling them, right, they may feel betrayed and may not want to follow up. It may take a few attempts to get them to accept help, but it's worth it to stay patient and try to enlist allies. See if friends or other family members can also mention to them that they have concerns and get them to seek care. But it's not always possible to wait. We really do need to focus on safety, especially when it comes to taking their own medication or driving. You want to make sure that an individual is able to do so safely. And if you believe they are not, you do need to act to protect them. And your local medical specialist can help provide you that support and resources that you need to make this happen. But remember, your goal isn't to win an argument. It's to stay aligned together to ultimately get this figured out and get the best care possible. So, how do you support a loved one without burning out? Caregiver burnout is a very common term in our field, and it has to do with the fact that when one person is trying to support another who is very impaired, they often forget to take care of themselves. It's very important to accept help. Nobody can do this alone, especially as the disease progresses and the affected individual becomes more and more impaired. It's very important to build a good support network. This can be local support groups, church groups, online communities, even your local memory center or senior center might have a lot of resources that might be helpful. Do prioritize self-care. The example that I give in all of my visits is on an airplane, in the case of an emergency, if there's low cabin pressure, these oxygen masks drop down on the airplane. And what do the flight attendants tell everyone is always put the mask on yourself first before you try to put it on anyone else. And likewise, to be a good caregiver, you have to take care of yourself. You need to have rest. You need to have exercise, and you need to do things that you enjoy outside of caregiving. Um, a phrase that I do like very much is that you can't pour from an empty cup. Your cup needs to be full before you can try to fill someone else's. And again, do use those community resources, respite care, adult day programs, meal delivery, transportation services, again, your local senior center. Utilize them. That's what they're there for. And remember, taking care of yourself is not selfish. It's essential. So for planning and support, early planning is very, very helpful for families, and that's why getting a diagnosis early on, even if there is not an ideal therapy, can be very, very important. That way, when things change and the situation changes, potentially more care is needed, you already have a plan. You're not playing catch up at a time that's already very, very stressful. Community resources can play a tremendous role here. So the key takeaways here are that not all dementia is Alzheimer's disease. There are other causes that have nothing to do with a neurodegenerative disease at all. And early detection really changes these care options. You are not alone in this journey, so do seek out help as soon as you notice concerns. Well, thank you all very much. And at this point, I'm happy to open up the floor to any questions. Zach, if we have any in the messages, maybe we'll start with those, and then we can also open up the floor to those who will want to unmute.
Sounds good. I didn't have any in the chat, but if you have some questions, feel free to come off of mute. You can also, under the React button, there's a way to raise your hand in case multiple people have questions, but feel free to jump off and ask any questions.
Yes, I have a question, and I don't remember if you may have touched on it initially. Is there any way to know if you're predisposed to dementia or Alzheimer's?
So that is a good question. And I'll say the answer is a little bit complicated. The most direct, I guess, kind of the most important information to know is for any definite risk, or I would say very, very high probability risk, the closest place you can look is your own family tree. The individuals that are close to being guaranteed to developing dementia are those where it happens at a young age. And by a young age, I mean usually before age 65 and happens in every generation. If mom had it and mom's dad had it and his mother had it and her mother had it, right? That in every generation somebody has it, and potentially siblings as well, usually at a young age. Those are the rare forms, but that are directly heritable in a way where if just one copy of a mutated gene is passed from the parent who was affected, then the next generation someone gets it too. But this is quite rare. What unfortunately is the situation in most of the population is we have genes that require a different type of inheritance, where one copy can slightly increase risk and two copies can significantly increase risk, but neither one actually guarantees developing the disease. And there is a gene like this that we can test for, but I'll tell you it's present in about 1/4 of the population. 1 in 4 people carries at least one of these risk factor genes. But again, what we know is that even having one copy that was inherited from either mom or dad does not guarantee ever getting the disease. And just leading a healthy lifestyle can offset those risks. And so some people ask me, should I get tested for this if I do not have a significant family history of the disease? And I'll say, well, here's my recommendation. If you get tested for this gene and the answer is you find out that you carry one copy, I would recommend you exercise, you have a healthy diet, you socialize, you kind of do all the things your primary care doctor recommends. And if you don't carry a copy of this gene, I would recommend exactly the same thing to you. So I'm not sure that testing will change any outcomes of what you do, except making you worry more. So I generally don't recommend testing for it.
Thank you.
Absolutely.
We had a question in the chat from, I believe it's Alyssa. I am not a legal guardian or relative of my friend who has dementia. What can I do legally?
Well, if your friend has dementia, I would hope that there is somebody involved in supporting your friend. And if that is a family member, again, you can help them identify resources to try to get the care that they potentially need. There are, for example, government programs that will pay for a lot of care for individuals with Medicare. Insurance plans will pay for a lot of care as well. So I would encourage them to seek that care because it could help them get, again, therapies and resources that might ultimately make their lives easier. I think the biggest misconception with this disease, and I'm talking about Alzheimer's in particular, is that people think that if you have it, there's nothing that can be done, and that's just not true.
And then another question we have are, what are some lifestyle ways to help with dementia other than drugs?
Absolutely, and I was alluding to that earlier. So one of the things, well, the main thing I guess I will say is the recommendations that your primary care doctor gives you are very important. A lot of the blood tests and kind of lifestyle interventions that your primary care doctor will talk to you about have to do with heart health, right? Eating a healthy diet, Mediterranean style diet, exercise. Well, guess what? Your brain has more blood vessels than your heart that supply it. And a heart attack is when one of those little blood vessels that feeds the heart gets occluded. Well, you have way more blood vessels in the brain. And when one of those gets occluded, well, that causes a stroke. And sometimes those strokes are so small that people don't even know that they've had little ones. But over decades and decades, they accumulate and they significantly affect brain function. So taking care of your cardiovascular health is also very much taking care of your brain health. Regular exercise, again, cardiovascular exercise, so staying active, not just lifting weights, is very helpful. I would say at least 30 minutes a day should be the goal for everyone. And your brain is also meant to be used. You can think of it in a way as a muscle that by using it and training it, it becomes stronger and more resilient. So keeping active in older age is very, very important. Learning new things, staying stimulated, and a big part of that, I think, now is leaving the house, is being exposed to new things, talking to new people, having interactions. Unfortunately, watching TV is a one-way process. You take in information, but you don't do anything with it. You really want to have a feedback loop. And that's where things like artistic skills, where learning to draw, taking a dance lesson are things that force you to create some sort of output and do something. And when that's also a new thing that you're learning to do, it's very, very valuable. Your brain cells, your neurons actually form new physical connections with each other whenever you learn a new way of doing things. And those then create backup systems for you if your brain is to be affected by other problems in the future. So socializing is one of those things that's very, very helpful. You do want to focus on good sleep and generally minimizing some of the kind of strongly sedating medications. If you have significant sleep problems, it's worth it to evaluate and find out what the underlying cause is. If you have sleep apnea, then treating that, potentially getting a CPAP or other treatments, if you can't tolerate a CPAP, can significantly, again, affect the trajectory of your brain health, because you really want your brain clearing out those toxins while you sleep.
Another question we have are what are some of the biggest challenges caregivers face early in the journey that people may not anticipate?
I think early in the journey, one of the most dramatic changes that I hear about is that the affected individual, if they still control any of their finances, may start making poor decisions. Unfortunately, a large reason why so many telephone scams exist is because they are targeting exactly these individuals who are starting to have impairments in decision making. They make all these calls because all they need is 1 in 1,000 people to fall for that scam, and then, send that $10,000 to Nigeria, and all those other calls were worth it. So when you start seeing kind of early questionable decision making, you really want to review the access to the finances and potentially even contact the financial institutions. You want to make sure that you have a power of attorney, which is a document that states, like a healthcare proxy, that if the affected individual has impairment in their decision making, that at that time there is a proxy designated who can make those financial decisions for them. And that's a document that you want to have completed before the individual is significantly affected, because it only becomes active when they are actually impaired. If you wait until they're already impaired, well, that document's not going to hold up in court because they didn't have the capacity to appoint whoever it was to make financial decisions for them at that point. But unfortunately, it's not uncommon these days to hear for people falling for these scams and giving away a lot of money unintentionally.
We had another question in the chat. My husband trazodone for sleep the last 10 years. Should he stop?
Trazodone is one of the safer medications that we have. At high doses, it's used as an antidepressant, but at low doses, it's a great sleep aid. It's one of the most common ones we use in the hospital for elderly. Of all the things that you could have told me he uses as a sleep aid, I'll tell you trazodone is okay. And while we're on that subject, I don't know if someone will bring it up. What I will tell you to avoid is Tylenol or Excedrin PM. When you see PM in the name of those medications, the active ingredient there is actually Benadryl, and the generic name for Benadryl is diphenhydramine. The problem with Benadryl is it's good for an allergic reaction because it decreases the release of some of these hormones. But in the case of sleep, it actually decreases the firing in the brain and decreases the levels of an important neurotransmitter. And when people use it regularly as a sleep aid, we actually find it slows down their cognitive functioning. So if you have an allergic reaction to something, or if someone even with dementia has one, it's okay to use a Benadryl on rare occasions, but it really should not be used by anyone, especially after retirement age, as a regular sleep aid.
We had some follow-up in here. Only the PM Tylenol? Question mark.
Yes, regular Tylenol is fine to use for pain, right? In doses that are okay based on your liver function. I believe the recommendation without any liver dysfunction is a maximum of 4 grams a day. But if you have any liver problems, talk to your doctor. You may need lower qualities. But regular Tylenol does not affect brain health in any way. It's only when they add the Benadryl to it.
Perfect. And then a follow-up question. I take hydroxyzine for sleep. Is it safe?
Unfortunately, not great. Not great. It has a lot of the same properties that the Benadryl does in kind of slowing down that neuronal firing. I would talk to your doctor maybe about that trazodone that somebody else brought up. There are a few other sleep aids which are safer in older individuals, but the older you get, the more concerned I get about hydroxyzine as a medication.
And then another question we had is, if a power of attorney won't work, if they already have impairments, what can you do?
So it depends. You may want, so I would say you probably want to talk to somebody at your local senior center, get some support for resources in your area. But essentially, it depends on if they still have control over a lot of their financial assets and if they're trying to use them. If you're aligned, and even if you don't have the power of attorney, but they'll listen to you, then maybe they can go to the bank with you and set restrictions, for example, of maximum withdrawals of $200 a day, right? Even if they call, just that way that they can't fall for a scam. If you think they're making really poor decisions and essentially you don't have the legal power to stop them, then unfortunately sometimes it has to go through the court, and that on its own is a lengthy and expensive process to do so.
Rudy?
Hi, Dr. Yerstein. My question would be, how do you approach conversations around driving safety with families?
That's a great question, Rudy, and unfortunately that makes me disliked by patients, not all that infrequently. Um, So part of what we do in terms of our cognitive evaluations at Synapticure is administer some testing that also evaluates visuospatial skills. And if people have trouble drawing complex shapes, like drawing a clock and all the numbers, for example, and they already are showing cognitive impairment, that makes us worry that there is trouble with their visuospatial skills. And that's whether or not the family has already noticed trouble driving. What I generally try to tell family members is, even myself doing that evaluation through a computer or them seeing the person at home, for example, we are not the best judges of whether they're truly a safe driver. But if we have concerns, that is the right time to get a formal driving evaluation. And while this can be done at a DMV or RMV, there are a lot of other places that will also perform a driving test, such as occupational therapy clinics. A lot of hospital systems will offer driving assessments. And those assessments consist of the same thing as what was required to initially get a license. Answer a brief, usually 10-question test and do the brief drive around the block and park and what have you. At the point when cognitive concerns emerge, that is the right time to get this testing completed. And again, I will always emphasize that it's not that it's the care partner or even the physician who's making this decision telling somebody not to drive. If it's truly questionable, we want to leave it to a specialist to do a proper evaluation. And I'll also say that there are plenty of individuals with mild Alzheimer's disease, people who are slightly forgetful, who don't have impairment in their visuospatial skills and still have that muscle memory for driving and can drive just fine. But what the nuance here is that usually, and what should be required for these driving tests is that they clear you for a period of time. They generally will say the person passed the test and they are cleared to drive usually between 6 and 12 months. And then it's recommended that they're retested because these are progressive disorders. And part of how I'm often able to convince individuals to get this testing is by emphasizing that, well, if they do get in an accident and they have not had one of these tests, nowadays people are very litigious, right? And they could sue and try to blame that individual and get their medical records. And if the medical records especially already mention cognitive impairment or dementia, right, potentially somebody could try to hold them liable or blame them even if it wasn't their fault. If that person can then show, however, that they just took a driving test in the past 6 or 12 months and passed and were cleared to drive, well, that could potentially protect them from significant liability.
We had another question in the chat from Viola, and Viola, please feel free to jump off mute if I um, repeat this incorrectly. But I got along with 2 to 3 hours of sleep for decades. No doctor ever asked me about my sleep habits, and I had problems with memory. Are they not trained to look for sleep issues? Now on CPAP, it's not progressing, but damage seems to have progressed.
So we need a lot more information to be sure of what's going on here. I'll say if you function on 2 to 3 hours of sleep for decades and you're not tired during the day and not napping, well, then congratulations to you. You have a super efficient brain and you're very lucky to have gotten that many more conscious years in your life because you didn't need to sleep. The fact that you're noticing cognitive changes now may or may not be related. But the fact that if you truly needed very little sleep and could function well on it in the past, that might have just been a fortunate, unique adaptation that you have. It's not necessarily a problem. Rudy, do you have another question, or is that still your hand is just up?
No, I do have another question. So, if a person begins to show concerning cognitive symptoms, should they consult a primary care physician, a cognitive neurologist, or a neuropsychologist first? What would you recommend?
So I would say it depends on access in your area. You want to talk about it with a specialist as soon as possible. Nowadays, wait times can be very long to see a specialist. So if you can get in quickly, that's the best time to do it. I always give the comparison now, unfortunately, of cancer. Nobody would say that, well, it looks like I have a mild cancer. I'm going to wait 6 months to really see that one specialist in that one place to really figure out what's going on, right? You want to have it evaluated as soon as possible because if you do qualify for a treatment, you want to get treated before it advances and progresses. So really, I think time is of the essence. See a specialist and see somebody who has a plan for what to do next. And if they don't take it seriously, we'll get a second opinion.
And then we had a question from Mary. I've heard that Alzheimer's can cause people to get paranoid, thinking that people are trying to harm them or steal from them. Is that true?
Very true. And usually this is not in the very earliest stages of the disease. Usually there is already significant memory impairment. What tends to happen is the individual themselves may take some of their own things and move them to a different place, then forget that they did so. They'll go to the original place and they'll look and not be able to find them. And now our minds are continuously trying to make sense of the world around us. And if they're confronted with this fact that this thing is not where I remember it being, our minds don't like having an answer, and the fact that they've forgotten is not available to them. So they fill in the gaps. And what do most people think? If something of theirs is missing, somebody else must have taken it, right? And over time, this can create whole complex delusions that there might be somebody sneaking into the house and taking their things. They might blame it on a family member or a friend or on strangers. And so what I was mentioning previously, some of this irritability or agitation that can happen, in particular with Alzheimer's disease, stems in part from the fact that people simply have blanks in their memory of facts that don't quite add up, and they try to fill in those blanks sometimes with elaborate delusions again that may unfortunately blame even their loved ones.
Um, Alyssa, you had a question on back to driving. Is driving very slowly bad?
It can be very dangerous if the individual is going on the highway. And we do notice that very slow driving is often a result of the person being really uncertain. They are driving slowly to give them more time to hopefully figure out what to do next. If the driving is so slow that others are starting to pull around them, that might be creating dangerous situations, right? Especially if you're dealing with narrow roads or single lane roads. Essentially, if you yourself driving as a passenger in the car with somebody whose driving you're concerned about has gotten to the point where you feel unsafe in the car, even if you can't quite put your finger on it, that's reason enough to get them a formal driving evaluation. Let's see if they're actually safe on the road.
Okay, so my husband had a TIA last year. So he's been on aspirin since then. And then he had a brain evaluation. And they put him on a CPAP machine. And he's also on something called MEMANTINE, HCL. So he's on that. But his short-term,
Sorry, I lost you after short term.
okay, his short-term memory is getting worse, it seems like. He'll ask me something, I don't know, 5 times. So I don't know what is it that we can do to help that?
So he might be doing some of the right things. The CPAP, if he indeed has sleep apnea, can be helping improve the natural clearance mechanisms in the brain. But that's usually not enough at the extent of deficits that you're describing where he's repeating himself. He needs a more formal evaluation with a neurologist, potentially additional testing to determine if indeed this could be due to Alzheimer's disease or something else. Memantine can be helpful and cause slight symptomatic improvement, but usually in later stages of the disease and is usually not our first line treatment. I recommend that you seek evaluation with a specialist, either locally or with us at Synapticure, with I think the website and number being available on your screen. But it sounds like it's progressed to a stage where you want to see a specialist now and not wait.
He's been seeing a specialist. He's been seeing a neurologist.
Understood. Well, have you been given a diagnosis?
No.
So I would say if there's no plan for the further workup, then you need a second opinion.
Okay.
The other thing I will say, and this is a good point, is when I say seeing a specialist in my field, it's true. A neurologist is a specialist beyond general medicine, but within neurology itself, there are probably 10 different subspecialties, and dementia care is one of those. So myself, after completing training as a general neurologist, I did several years of additional training in diagnosing and treating these various dementia syndromes. So you want to go to somebody who specializes in memory care because again, generalists cover a little bit of a lot of different things, but you want somebody who focuses on this at this point.
Great. Thank you.
You're very welcome. I will say these have all been excellent questions. And if you're holding one back because you're not sure if it's relevant or silly, I'll tell you, I bet you 5 other people on the call are thinking the same thing, and it'll help them if you put it out there. So if you have a lingering question, please don't hesitate, even if you've already asked one before.
And I always throw this out there too. This is a free visit with Dr. Yerstein here. You're not paying to see him, so ask away.
And there's no wait. You
And
get
there's
your
no wait.
And where are you located?
So I am personally located in Nashville, Tennessee, but I can see patients right now in 31 different states via telehealth, and through our company Synapticure, we see patients in all 50 states. So as long as you're in America, we can see you and do a full evaluation.
Okay.
Melissa had a question on where can I take my friend for an eval if his primary refuses to listen.
I would look at the website or phone number on your screen. Again, you can look up memory care. You can go to a local facility if there is one. A lot of academic hospitals also do have a dedicated neurology subspecialist who specializes in memory if you live near a large enough center. But I'll tell you the typical wait now is about 6 to 12 months to see a specialist. The wait for us in Synapticure now is about 2 to 4 weeks.
We had a question, is it helpful to do puzzles, crosswords, word searches, etc., to keep the brain healthy?
Yes, as long as you find it interesting and challenging and stimulating. It's good to do things that challenge you a little bit and you have to work hard at it and problem solve. If it's too easy and you just do it mindlessly without thinking about it, it's no good. Switch to a different task. So if you're really good at crossword puzzles but bad at math, maybe switch to Sudoku and do it until you get good at it. And once that becomes too easy, switch to something else. The key is challenging yourself to learn something that you couldn't do before.
And then Kathy was asking, is a doctor referral required?
Not for Synapticure.
Patricia, I saw that you came off mute. Did you also have a question?
Yes. How long, how long are infusions given to a person who has dementia or Alzheimer's? I guess Alzheimer's.
Right. Generally 12 to 18 months. The studies ran for 18 months, but for some, we could do a scan after just 1 year and see if kind of some of these proteins have been cleared out. But then after the initial treatment course, there can be a discussion of whether it makes sense to do maintenance therapy or not, which would be less frequent, but potentially keeps going until somebody has such impairment that we think it's not indicated any longer to keep going. So these infusion therapies are really indicated for individuals with what's called mild cognitive impairment, which is when you notice symptoms, but they're not yet affecting daily life, or mild dementia, when only kind of complex functions are affected, but basic functions are still preserved. When the disease has unfortunately progressed past that mild stage, these therapies don't seem to have any further benefit.
Thank you.
You're welcome.
We have a couple questions about the insurances that we accept.
I may defer that to our
Yeah.
intake specialist, Rudy. As a clinician, I'll tell you, I have no visibility on what happens with insurance or payments or anything like that.
Yeah, and I can chime in here on some of those. So across the board, we are a traditional Medicare Part A and B provider. So if that is the primary insurance, 100% you can come and see us. Outside of that, the Presbyterian, Medicare Advantage plans, commercial plans, United Healthcare, um, there is Blue Cross Blue Shield. And then for other insurances, it's really dependent upon the plan. Some of them are very specific about what they cover. So I always recommend that you just give a call to the number listed on the screen here. Rudy and her team are phenomenal at evaluating every single insurance. And even if it is something that we might not be in network with for insurance, we may be able to bill it out of network with lower copays and things like that. So it's definitely worth a chance just to reach out and talk to the team and see how we can help. And then we had a question about what is the connection between eye-hand coordination and memory, i.e., woodworking or knitting or jigsaw puzzles.
I would say it's quite broad in that, in general, when you learn to do something new, and whether it's with your hands, as I mentioned, artistic abilities, woodworking, your brain still has to kind of organize all of the neurons to plan that activity, to execute, right? And your brain is kind of the puppet master for your body, coordinating your muscles to do all of these things in a very particular way. So learning a new skill like that very much engages the brain. It forces it to focus, coordinate its activity and do something in a particular way. If that's something you are interested in, you enjoy doing, and you find it stimulating, it's worth doing. And in terms of losing coordination with age, so for example, there are studies that show that people who develop more advanced dementia will often also have balance problems. And what we're finding is that as the disease progresses, it increasingly affects the whole brain, including eventually the areas that affect coordination as well. So it's not uncommon in later stages of the disease to see those things become more impaired. But as you may have guessed, people who were professional dancers, right, or were on their feet a lot, have longer preserved balance. And even people who continue walking actively, even when they develop symptoms, because they're engaging those systems, despite there being a slow decline, they're kind of working on that system actively, and it slows down that rate of decline.
Would septic pneumonia contribute to dementia?
So, in a way, potentially. As I mentioned, even with the urinary tract infections, if the brain is already predisposed, and because these conditions like Alzheimer's slowly develop over potentially decades, something like a septic pneumonia can overwhelm a system that was barely compensating and throw it into complete disarray. And so it's not uncommon for a severe illness or even episodes of general anesthesia for an unrelated surgery to unmask what was already a slowly progressive neurodegenerative disease. Essentially, these great stressors to the brain just lead to overwhelming the compensatory mechanisms that were helping a person keep it together who was already slightly affected. So I would say try to avoid septic pneumonia as much as you can.
Rudy?
Thanks so much, Zach. I just have a final question. Would a condition such as COVID lead to cognitive decline or even dementia? I've heard folks being worried about COVID causing like brain fog. Well, what is your take on that?
Great question, Rudy. You're full of good questions today. What I'll say, yeah, COVID, right? We're still not fully understanding the extent of this disease, but it's so common for me to hear that people first notice their symptoms right around 2020 or 2021 when they were sick with COVID. So this virus causes inflammation throughout the body and can affect most organs, including the brain. A lot of what we're understanding now as COVID brain fog has to do with this kind of global inflammation that happened from COVID in the same way that septic pneumonia or a urinary tract infection could cause it, but sometimes worse. So people who may not have otherwise developed symptoms for another 5 years, now they were unmasked that much earlier just because of how severely overwhelmed their system was at that point. Now, And other individuals with other, say, neurological illnesses may also have suffered more from COVID, again, because their system was already more vulnerable. And then COVID may have made it harder for them to recover. And we think that a lot of brain fog was exactly that. Maybe a subtly injured brain that then suffered a second hit that then really took a long time to recover from. But most individuals who are otherwise have good brain health, even if they suffer from COVID and are quite impaired, generally do recover their faculties.
We have one more question in the chat here. How likely is a person diagnosed with Parkinson's disease to develop dementia?
So we have a lot of data on this, and it's all about time. So Parkinson's is a neurodegenerative disease like Alzheimer's disease, but it progresses in a very different way. Parkinson's generally affects the movement centers of the brain first and very slowly progresses to affect other functions. So given enough time, it does likely cause dementia. So in other words, for individuals diagnosed with Parkinson's disease, if they live another 20 years, 80% of them, so 4 out of 5, would be expected to develop dementia.
And then Rita had a question. It seems like it's a follow-up to that, or a hearing loss.
Hearing loss, and if we leave on that point, that's a very good one to leave on. So hearing loss is a correctable, modifiable risk factor for accelerating dementia. So in the same way that our brain gets stimulation from all these hobbies or activities or even socializing that we're doing, well, if you have hearing loss and you don't correct it, then there are large parts of your brain that are not getting the stimulation they're supposed to. And this creates additional isolation, and then people withdraw, and then their world gets smaller, and they do less, and they use their brain less, and it's kind of a downward spiral. There are multiple studies now showing that correcting hearing loss can drastically lower the rate of cognitive decline. It doesn't stop the Alzheimer's disease in itself, but it gives your brain, again, this additional exercise and stimulation. So absolutely, I recommend everyone get at least an annual hearing test. And if you are advised to use a hearing aid, you do so. They're much less expensive now than they used to. And there's also something called a personal sound amplifier now, which is basically over-the-ear headphones that connect to a little microphone. They're very, very inexpensive, and they can help increase that hearing. So if yourself or a loved one are turning the TV way up high just to hear it during the day and annoying your spouse, you need a hearing test and probably need a hearing aid. And the sooner you do it, the better for your long-term cognitive health.
Perfect. Thank you, Dr. Yerstein, and thank you everybody for joining. As mentioned earlier, I will send out a follow-up email with a link to this recording. But I appreciate everybody being able to join us, and I hope you all have a wonderful day.
Thank you all for your excellent questions. I really enjoyed answering them and enjoyed the variety and the breadth. It has been an absolute pleasure. Take care. Have a great day.